I will be talking to you in this this first talk about the Shine trial, focusing on the findings and the implementation considerations that came with it. Um, and basically my talk will cover. I'll give a bit of background and context, and then provide you with an overview of the Shine trial, the design, and the main findings, and speak about the adaptations of the findings in different countries, and also then summarize my talk. To get us started, I think we remind ourselves that close to 1 million children every year develop TB, and it's estimated that one in every five of these children die from TB. And the majority of the deaths actually are occurring because children were not diagnosed and they were not treated. And children below the age of 5 are very active in terms of disease burden and in terms of mortality as well. And then we also have this peak along around the adolescence period in childhood. And it's estimated that out of all the children with TB, an estimated two-thirds actually have non-severe form of tuberculosis, which was the basis for the SHINE trial. Um, and then just reminding ourselves again about treatment shortening. We know that part of the global strategy to end TB um, is that treatment shortening is actually one of the top priorities of the end TB strategy. And it makes perfect sense because if you treat people for a short duration, that has the potential to improve treatment completion, reducing on the toxicity because they are on treatment for a shorter period. And also this would likely have a bearing on the health cost and the cost to the families. And we know that there were some historical trials in adults that showed that non-severe possible ciliary disease or smear negative TB disease in adults could be shortened. And this was confirmed by post-hoc analysis of recent TB treatment trials of adults. And therefore, there's potential that in children who were already mentioned should have a fair share of non-severe disease, that this sort of approach could be applicable to them. And so this is where the SHINE trial came in. So the SHINE trial basically asked the question on whether it's possible to reduce TB treatment from the standard 6 months to 4 months in children who had smear negative, non-severe, drug susceptible TB. And trial recruited children who were aged below 16 years who met the trial defined criteria for non-severe disease. And these children were then randomized in a 1-to-1 ratio to receive the standard 6 months of treatment then, and also to the trial 4-month regimen. And the difference between the regimen was that in both the standard and 6 months and the shorter 4-month regimen, the intensive phase was of the same duration of 8 weeks, but the difference was in the continuation phase. In the 4-month regimen, the continuation phase was ended after 8 weeks. And then children were followed up for a total of 72 weeks, and there were several studies that were nested in this trial, including pharmacokinetic studies. And like I explained, basically the difference between the two regimens was the duration of the continuation phase. And then children were dosed according to the WHO dosing guidelines, and they received the fixed dose combination tablets that are child friendly. The trial was implemented in 3 sites in Africa, and 2 sites in India. The sites in Africa were Zambia, Uganda, and South Africa. And in India, we had Pune and Chennai. And so this was the main trial inclusion criteria. Children were included if they were below 16 years and they weighed more than 3 kilo. They were of a no known drug resistance, of a non-HIV status, and they were recruited on the basis of a clinician's decision to treat a child for TB, and they should have been smear negative on a respiratory sample. Um, and then they were deemed to have a non-severe, symptomatic non-severe TB. And post-bacillary disease in this trial was defined as being either sputum smear negative, and at the time that the trial started, actually the smear microscopy was a standard, but expert became available, so the expert was also used if the child was smear negative, but expert negative trace or very low or low was included. And then non-severe disease was defined based on radiological features, and these features were pathology in less than one lobe with no cavities, no airway obstruction, no complicated pleural effusions, and no miliary TB pattern. And peripheral lymph node disease was also considered as non-severe TB. So the main findings of the trial was that it was shown that 4 months was non-inferior to the 6-month regimen. And so therefore it was as good as the standard 6 months, and the unfavorable outcomes were actually comparable in both arms, 3 months, 3% unfavorable outcomes in both arms. And there were other findings, including that pre-specified subgroup analysis basically were all in the same direction, that there was no, the 4 month was as good as 6 months in terms of HIV status, excuse me, the region, the sex, age, and weight band, and all the pre-specified subgroup analysis produced consistent findings, and safety outcomes were similar. And the cost-effective analysis showed that the treatment, the 4 month treatment reduced healthcare costs by $17 per child. And so this then was formed the basis for the WHO 2022 revision of the child TB treatment guidelines, where the 4 month regimen was recommended as an alternative treatment for children with non-severe TB. And the WHO provided an eligibility criteria which mirrored some of the SHINE finding criteria. Children aged between 3 to 6 months who had radiological non-severe TB disease and with no suspicion or evidence of MDR TB, and also provided a clinical criteria that they would have mild symptoms, not requiring hospitalization, basically not having any danger signs. So some of the implementation considerations in this adoption of the trial is what I'm going to go through in this section. So if the trial used smear negative as a criteria for determining that the child had post-bacillary disease, and by the time the trial ended and these guidelines were made, the recommendation was made, WHO expert had become widely available as a preferred diagnostic tool. And therefore the challenge was then, how do you then translate the use of smear to the use of expert? So here the solution was that experts could still be used, but and semi-quantitative results would be used to define post-bacillary disease, or if it would be post-bacillary if the child was expert negative, had trace expert, very low or low. And obviously then it meant that for the child to meet optimally to meet the criteria for non-severe, then we needed to sample, to provide a respiratory sample, and therefore there was need to train healthcare providers. Excuse me. So there was a need to provide training to healthcare personnel in order to get samples from children. And also at this point, there was an opportunity to use two as an alternative to respiratory sampling, because it was around the time that it was also recommended. So it could be applied in settings where gastric aspirate, nasopharyngeal sputum inductions could not be done. The other consideration was the radiological criteria. So within the trial, there was an elaborate criteria to classify a child as non-severe disease based on the chest X-ray. And there's already a publication that you can refer to on how this was how it was approached in the trial. But basically, the clinicians in the trial were trained on how to do severity assessment, and there was a specific atlas that was developed that guided the trial clinicians. And if you this report, it actually showed that this severity assessment was quite conducted quite fairly well between the local clinicians and the central reading team. That didn't seem to be much discrepancy between these two teams. But then, so how would you then apply this in real life situation in real clinical practice? So here, the obviously then the healthcare providers need to be equipped with chest X-ray reading in order to understand what is severe disease and non-severe disease. And there are some resources that have been developed, including the Union Diagnostic Atlas for Pulmonary TB, that can guide healthcare providers. And this also comes with an e-course that can be used. There are also opportunities with the widespread use of portable and digital chest X-ray machines, and also the potential to use computer-aided pediatric chest X-ray reading, which currently there is no validated tool for expert, but it provides a potential opportunity for radiological classification. So the WHO guideline, taking into context all these consideration, actually provided for different scenarios on what you do in a setting where you have all the optimal conditions. You had a capacity for chest X-ray, to do chest X-ray, and the capacity to interpret images, and also bacteriological testing. So in this scenario, then you can use chest X-ray features to do disease classification, and also use the bacteriological classification using expert ultra, and apply the clinical criteria. And in the settings where you have no access to chest X-ray, but you have access to bacteriological testing, here again, then you use the expert reading to guide you on determining which child would be eligible, as well as application of the clinical criteria, and also making sure that the child is closely followed up to make sure that their symptoms, they are responding to the treatment. And lastly, in setting where they have neither chest X-ray and bacteriological testing, for example, in that primary healthcare setting, and in this setting, you would only be qualified to treat a child if they have isolated peripheral lymph node disease, which is deemed to be of tuberculous nature, and they have no danger signs as well. And it provided the clinical criteria that you use to determine who has mild symptoms not requiring hospitalization. And so a number of countries started early implementation, and I'll give you an example of basically what happens when the guidelines are recommended, and what's the processes that that countries go through. So WHO issues guidelines, and then within countries usually review these technical guidelines, and they usually use either expert groups in the country or technical working groups that are associated with TB programs. Then they develop a policy framework, and they usually then have to change guidelines and include these recommendation within their national treatment protocols, and then they go out and start country implementation. And then once they implement, they still do monitoring and evaluation and provide mentorship, and also they can revise these guidelines based on the feedback that is coming from regular practice. And so some countries were early implementers, if I can call that, and I've given you examples on how they went all the guidance that they provided. I'll give an example of Zambia, Kenya, and the UK and Spain, who implemented in 2023, which is just, I think, a year after this recommendation were made. So, for example, if you look at the eligibility criteria, Zambia used the WHO definition for the age, and the UK Spain also used the same one. But if you look at Kenya, they limited it to children between 1 year and 10 months and excluded infants. And then when you look at the severity criteria, the WHO criteria was used, but there were some exclusions. For example, in Zambia, they excluded children with advanced HIV disease, and in Kenya, any child who had bacteriological positive test, whether on smear or on expert, was excluded. Any child who was HIV positive was excluded, and any infants were excluded. And in Zambia, they conducted a phased implementation where two regions were selected to start implementations before a countrywide rollout, whereas Kenya implemented countrywide and the European countries implemented countrywide as well. And here's an example of what the specifics and what modifications and adaptations, for example, in Kenya, as I already alluded to, they made exceptions for children, for infants and anyone above the age of 10 years. And they indicated that this could only be the child could only be treated if they were stable enough to be managed as an outpatient. They excluded all HIV positive children and severely malnourished or immune suppressed. And they excluded anyone who had a positive bacteriological test. And the other example is South Africa. They then they basically they provided a scenario where chest X-ray and bacteriological and radiological services were provided, and this pretty much mirrored the WHO criteria and the SHINE criteria as well. But they made exceptions for setting where there was no chest X-ray, whereas the WHO criteria doesn't provide any age cutoffs. In South Africa, they specifically then provided an age cutoff that without a chest X-ray, children be above 8 years and above could not be treated without chest X-ray support, and anyone who was HIV positive who could not be treated if there was no chest X-ray. And this slide basically summarizes as of 2024, based on the information gathered by the WHO, the countries that had or started implementing these guidelines. There were 26 countries that were implementing this. We will hear from Berta's presentation. She has more up-to-date figures on how countries are implementing, and the countries that accounted for a big contribution of children who were initiated in the 4-month regimen included Kenya, Zambia, and the Philippines. And the WHO has also got to promote the adaptation of this 4-month regimen. They've developed a protocol, an operational research package similar to what was developed to encourage the uptake of the treatment decision algorithm, and we will provide a protocol, and this operational research will aim to answer questions around the absorption, fidelity, feasibility, acceptability, and efficiency and cost impact of the 4-month regimen for non-severe TB. So, in summary, the SHINE trial showed that treatment for 4 months was as good as a standard 6 months treatment for children with non-severe TB, and that unfavorable outcomes were comparable in both arms with no major safety concern, and the intervention was associated with reduced healthcare costs. And the WHO then recommended the 4-month regimen, and since then there's been a gradual global uptake of the 4-month regimen. And to successfully implement the 4-month regimen requires investing in diagnostic capacities and practical tools and health care training and equipping them for the capacity to do that. and therefore this requires ministries of health and national TB programs to support the delivery of the intervention to adapt it to different settings. So just to acknowledge the Shine trial team, Dai Gibbs, the main investigator, Anna Turkova was a clinician in the trial, and there are many, many more other colleagues who participated in this trial. Thank you, and over to you, chairs.
So in the next 20 minutes or so, I will be presenting some preliminary results from a questionnaire that we launched last month. And the idea behind it was to try to assess the uptake of the Shine shorter regimen a bit more globally across the world. So we've heard from Chishala of a few examples in Kenya, Zambia, UK and Spain, and also South Africa. So I'm going to try to give a bit of a broader picture with our questionnaire. And just to say that this is part of a bigger project where we're trying to assess the impact of Shine worldwide. And I'm working together with Chishala, Anna, and Aigib, and also with a collaborator based in Vietnam. So watch the space, girls. We're going to keep working on it. So the main reason why we launched this questionnaire was because we wanted to understand to which extent the Shine regimen was incorporated into local and national guidelines, to have a better idea of how widely the 4-month regimen is being implemented in clinical practice in different countries, to understand the current clinical practice in different settings, and also to identify the main barriers of implementing the shorter regimen. So we shared the questionnaire via our networks, and that included the WHO and also contacts and colleagues who are based mainly in Asia, Africa, and also Europe and the UK. So in this slide, I'm listing the specific organizations and networks that we have used to distribute this questionnaire. So obviously, there is a limitation here that you can already appreciate. This is probably not reaching everyone, but we're trying our best. And if we can have your help on distributing, that would be great. But that's my end slide call of action. So basically, as I just said, these are preliminary results. So this is a questionnaire that is still open. And we aim to still collect data until the 1st of August. But so far, at the time of this analysis, we have 79 people who took the questionnaire, and they represent 44 countries in total. So there's a map here where you can appreciate which countries we have responses from. Some have more responses than others. We have a higher number of respondents from Nigeria and Italy. Then we have 4 from Thailand, 3 from Spain, the UK, South Africa, Zambia, Indonesia, and Papua New Guinea, and then 1 or 2 from the rest of the countries. So we went ahead and grouped the respondents by region, to have a bit of a better idea in terms of settings, high income settings and low and middle income settings. How was the representation of the answers we gathered? So we had 29 participants from high income countries, which include Europe, the UK, Canada, and Australasia. And then we had 50 respondents from low and middle income settings, including Africa, Asian Pacific, and Latin America. And here in this table, you have the specific countries we have answers from with the number of participants in brackets. So to know a little bit more about the respondents, we asked them about what was their professional background. And as you can see, most of them are pediatric doctors. So you could choose more than one option in this question. So we do have also other doctors that are infectious disease specialists or general practitioners. We also had 10 academics, 9 research, and 2 of them working in policy or TB programs. So when we looked at the type of facilities they work in, most of them said they work on tertiary hospitals, and this is something that we need to keep in mind throughout the entire presentation, because we had a much smaller number of responses from people working in primary care hospitals or in district hospitals or private hospitals. We also had a decent representation of people working in academic or research institutions, 29 of them, and one from an NGO. And most of them, they work in urban areas, as you can see in this pie chart here, so 72%. So at this point, I'm going to pause a second and say that we are aware that one person from one country doesn't mean the whole country, but that's the information we have and that's what we can work on. But one person doesn't necessarily represent what's going on in that country. It's just an example. And as expected, and you will see across the presentation, we have some contradictory results from people who live in the same country. So to have a better idea of the TB burden in children in each of the countries that are represented in the questionnaire, we asked the participants the number of cases diagnosed in their institutions last year. So how many pediatric TB cases last year were reporting in their institutions, and the results are plotted in here. Some countries didn't know, so they basically didn't respond. But for the ones we have information, basically results indicate that the highest TB burden was reported across countries in Africa and Asia, with more than 1,000 cases in India, Nigeria, Papua New Guinea, South Sudan, and Iraq, which are the ones shown in dark red in the map. Whereas you can appreciate respondents from higher income countries like Europe, UK, and North America and Australia generally reported a much lower numbers of pediatric TB cases. We next went ahead and asked if they were aware of the SHINE results, and 22% of all the respondents said yes. And the ones that say that they were not aware include participants from Indonesia, Liberia, Namibia, Nigeria, Pakistan, Senegal, South Africa, interestingly, which was part of the SHINE trial, and South Sudan. And some of them were not sure. And then when we looked at the changes in guidelines, we asked participants if the 4-month regimen had been incorporated into their local or national guidelines, if they knew if they were updated. And these results showed that 33 countries, so we're looking at countries now, have updated guidelines, 16 haven't, 7 are in progress, and 1 isn't sure. Now I put here a table because I think it's a little bit easier to see the actual countries and all the contradictions that we've been finding with responses. So when you have a look at the data in the table, we found a few discrepancies. So for example, the UK, it's in the yes category, but also unsure. And we just heard from Chishala as well. We know the UK has updated guidelines and we know where to find those guidelines. Same with Spain and South Africa. So some of the answers, we know they are probably untrue and wrong, but some of the others, we just lack the information. And it could be some cases, for example, that there is an updated recommendation, but not necessarily an updated guideline per se, which makes things even a bit more challenging. So next, we wanted to know if countries have incorporated the 4-month regimen into clinical practice. So the results show that 26% of countries from the 42 that we have data are currently using the 4-month regimen. And also we have 9 countries who are not using the shorter regimen. And this is a map of the countries. So the ones that are not using it include Papua New Guinea, Iraq, Cameroon, Guinea, Tanzania, Austria, Senegal, and Liberia. And then there's some that are unsure, which they include both people who replied, I don't know, and also when we have conflicting answers from people from the same country, we just pack them together. And again, we know some of them that are unsure, like Spain, South Africa, Philippines. We actually know that they are most likely using the shorter regimen is maybe not implemented widely enough that everyone has an awareness in the country. And then we compared, so that's the same graph that Chishala showed earlier. We compared our list of countries using the SHINE regimen with the countries from the report, the WHO in 2025. And we're pleased to see there's a lot of overlap. So all of the ones circled in blue, they're in both cases they were identified. There's a lot of countries in the report that we don't have data from. So probably they're still implementing it. I doubt that they stopped implementing it. But we do have data from new countries that were not in this list that, according to our questionnaire, they're using it. And that's an additional 19 countries that are using the shorter regimen. And then we went and asked to those who are actually using the SHINE regimen, to what extent they're implementing it. Are they using it for all eligible patients, or is it more a case-by-case scenario? And for these, we had 55 responses who were representing 34 countries, and 18 responses, 18 countries said that they use it for all eligible patients, 9 countries on a case-by-case, and then we have 7 countries where we had conflicting responses, so we kind of assumed it was a bit of a mix in between the two of them. And this is the same data, just showing them in a map with the specific countries. So I'm aware this seminar is being recorded, so you can always go back and check this this information. So then we went ahead and asked for the benefits or the potential or the perceived benefits of the shorter regimen versus the 6-month regimen. And they include reduced treatment burden, which we had 37 people reporting that, then improved adherence and caregiver satisfaction, similar outcomes than the 6-month regimen, and reduced loss of follow-up. We did not have any responses saying that there were no benefits, which is quite positive. And then we also wanted to explore what were the main initiatives that have helped to encourage people to use the 4-month regimen in clinical practice. And the most chosen one was the local adaptation of recommendations, which involved engagement with national experts, guideline committees, healthcare workers, and communities. That was the one that really made a difference. And then also, you've been mentioning already, practical tools and training, clear guidance and algorithms for different settings, and then also investing in implementation and country champions to drive adoption. Other interesting things that helped the uptake included WHO endorsement and also research embedded within the practical rollout. And I forgot to mention, but for this one, we had 56 responses. And finally, we explored what were the barriers to adopting the 4-month regimen. And the main barrier seemed to be the lack of training. Although we know there's been some training, endorsed by the union and it's freely available, there's, for some reason, that doesn't seem to be enough. And this is followed by the clinician reluctance to change practice. And we've mentioned already the difficulty to interpret chest X-rays and the limited access to them. Also the need for local evidence, concerns about TB relapse, and also an awareness of the updated guidelines, concerns about safety, or the results maybe not being endorsed by their national TB programs, or maybe not applicable to their geographical settings. And interestingly, within the others, we had some respondents saying that they actually found no barriers at all, and they were all from high-income countries. And then for those selectors in the box, so clinical reluctance to change practice, the barriers related with the chest X-rays and the concerns about efficacy, we went on and asked, can you give us more details about your experience on that? Because we wanted to understand a bit more. So when looking at the limited access to chest X-ray and the chest X-ray interpretation barrier, the main themes were, again, limited availability, difficulty in interpreting, and it's variable in between clinicians, limited training, lack of standardized approaches for assessing TB severity, and limited access to pediatric radiology experts. So basically, these are some of the answers we got, saying assess not severe TB disease is tricky. A lot of our health facilities don't have an X-ray machine, and others. About the barriers and concerns about efficacy and safety, there's still some caution about whether shortening the regimen provides the same outcomes that the 6-month regimen. So some people, showed the belief that 6 months is safest and the most effective option, that there's a lack of real-world implementation evidence, about concerns of applying the SHINE findings outside trial settings, or concerns for children with other comorbidities like HIV or malnutrition. And these are some of the actual responses, including local evidence and multi-center implementation that are needed. Most of us hesitate that shortening regimen would result in comparable efficacy, etc. And finally, the last barrier, which is probably the hardest to change, is reluctance to change practice. So clinicians have been prescribing 6-month regimen for a very long time, and it's really hard to change that. It's very challenging. Sometimes there's not enough awareness of the trial results or the SHINE regimen. Some countries, as we've seen, guidelines have not been updated yet, and there is a bit of inconsistency implementing the shorter regimen across healthcare facilities. And these are quite long, but these are some of the views from clinicians who are hesitant to change to the shorter regimen, saying basically not familiar enough, giving 6 months, and they prefer the longer regimen. So it seems to be quite a difficult one to change. So a little bit of a wrap up. The conclusions, and again, this is preliminary analysis. We know that the reach of this questionnaire is limited. We're aware about that, and possibly biased. These results are just preliminary, and the questionnaire is still open, and we're still collecting data until the 1st of August. We see that there are more and more countries updating guidelines and implementing the 4-month regimen. And the main barriers, according to this questionnaire, include the chest X-ray access and interpretation, limited training, and clinician reluctance to change practice. So what are the next steps? We are still collecting answers, so please, if you work on pediatric TB and haven't completed, there is a link here. I'll put it in the chat after my presentation, so you can complete the questionnaire. It takes about 15 minutes, so get a nice cup of tea and complete it. There's a QR code here as well if you prefer doing that from your phone. And also please share it with any relevant colleagues and networks if you can. Really, really appreciate your support. And then the final analysis of the results will be completed in September, hopefully, and we plan to share findings with relevant stakeholders and potentially publish the results. And that's it. Thank you so much for your attention.
Maybe just a few reflections. At first, I thought that SHINE will be very easy to implement. My ignorance with implementation science, because it's the same drugs, the same formulations. It's just kind of chopping the last 2 months so there is no need of introducing kind of new drugs or new approaches. The only challenge is whether chest X-ray is required or not. But WHO were very good to provide a handbook and advice which children we can use shortened treatment even if the chest X-rays are not available. Surprisingly, it takes quite a long time. Even after the guidelines adopted and fully supported with really kind of good confidence in the results, it takes a huge amount of time to get into the countries for the guidelines, national guidelines to adopt, and then actually to see that in practice this is implemented. It's a huge amount about due to champions in the countries. We can see the brilliant results from Kenya when it was pioneered by one of our colleagues. Kenya was not even part of the SHINE trial, but they embraced the TB treatment shortening, and there was very a huge belief that it's very useful treatment, and it's benefiting for lots of families and children. And it's on the other hand, even countries who took part in the trial, like India, there is a lot of discussions and still discussions, debates ongoing, and there is a reluctancy to introduce to shorten the treatment in kids. And you said, interestingly, we also can see from different countries, even if the guidelines are there, we know because we know we get access. Some people have lack of awareness, even those who practice and treating children with TB, which is interesting to see. So it just tells me, implementation is a whole new world of research science. And Tiso, I know your group is working a lot on social science and implementation studies. So what are the lessons learned? What would we need to do differently with the next trial maybe? Do we need to do different trials? Do we need to think about upfront implementation work? Or what would you do different?
So my response to this will be, I think, on my own, because we haven't done a social science study on this. On my experience in Malawi, we actually, we picked up the guidelines. I saw the slide say 2025, but the guideline came out Q3 or Q4 2024. But there is, my experience, some hesitancy. Clinicians in some of them it's very easy. But I think it would be great if there's some implementation science or social science work done elsewhere or wherever, because I see variable responses. Some are actually worried that the child won't get better. Some are worried because they can't confidently classify that this is not severe TB. So the gap that TB diagnostics is an issue is really quite big, and I suppose that would be an issue, because TB diagnostics in kids is not easy. Also hesitancy of it depends on the setting, because there's that clause of outpatient. So most kids also, not a good proportion of kids actually get diagnosed as an inpatient when you see you've tried this, you've tried that, but it comes back to the diagnosis. So I guess in the implementation world, it'd be great if we thought around barriers and facilitators, whether it's this study or other similar studies where we have shortening treatments for a disease that is as scary as TB, because it is scary. So that's where the hesitancy also comes up. So those are just my thoughts, but it's not research-based. I think it's just my own experience in meetings and as well as on the ward. I don't know if other people have any similar experiences to raise them. I see, Di, your hand is up.
Hi there. Well, I don't want to get in the way of any questions, because I was just going to make a couple of reflections, rather like Anna did. Sorry, there I am. Yeah, I mean, it's interesting because when we're just over 4 years since the trial was published, and I suppose because it was actually 2022, Anna, not 2021. And I guess the guidelines came out the same day, and that was partly because Chishala and the WHO team were also involved. So if you like, that was a gap that wasn't so big. What I was struck by hearing the Kenyans present is just what a lot of work it is to go on the ground and retrain healthcare workers across the country to have a different approach and it's a stratified approach. In other words, you've got to decide whether the child has severe or non-severe TB. And I'm sure that's where one of the biggest barriers is. And maybe Chishala can say a little bit more about this, because I know he's been looking in Zambia and Mozambique, I think, at what's happening at primary healthcare, primary care level. I mean, I think the other voice, which is important, it did come out, there was a little video of the trial as well, of the Shine trial, where a mum was talking about, she had one child that had severe TB and was treated for 6 months, and then the 2 other kids who were non-severe but had TB and were treated for 4 months. And I think one of the things that happened during the trial and was the realization that actually TB could be non-severe if you picked it up early. So that comes back to your question about or your issue about diagnosis, and early diagnosis is required in order to be able to do this. I think the final thing I was going to say is I find it quite interesting that it has been taken up, I think, quite widely in high-income countries, even though the trial was done in Africa and India. I think because they can do chest X-rays, they do chest X-rays, and yet still not implemented in India, even though they were part of the trial. They haven't changed the guidelines yet. And again, I tried to find out a bit more about why that was, and I think concerns from concerns about chest X-rays, not only doing them but interpreting them, particularly at lower level health facilities. So thank you. That are just a few thoughts from me.
Thank you, Di, and for your thoughts. I think Chishala also, you have hand raised.
Yeah. Thanks. Just my thoughts as well, and also just based on some of the experiences I've had from the Zambian side, as well as part of what Anna mentioned, the Decide TB project, which we're implementing in Zambia and Mozambique. First of all, in terms of the uptake, sometimes also it takes time for national TB programs to change the way they do things. So when a new thing comes on board, they need to change their guideline, change the way of reporting. They have to change the way they quantify drugs, and they have to change their monitoring and evaluation tools. So that whole process also contributes to what we see as a slow uptake, because they have to go through this process to change it. And then the other issue is that also national TB programs need to get a buy-in. In the case of the Shine, it's very helpful that WHO adopted. Usually when WHO recommends, countries are less reluctant to implement. I've seen there's a very big difference between the changes to TB guidelines, how long it takes them to be adapted compared to HIV guidelines. HIV guidelines are usually very quick to be adapted. And I think one of the challenges with pediatric TB regards the issue that, first of all, they have to diagnose. They are not even sure about the diagnosis, and they may not have chest X-ray access, especially in the lower district level setting. You will find they will do a chest X-ray. It will be poor quality, and if they go through that definition, they can't even see half the things that they need to see for them to classify the disease. And therefore, as part of the implementation process, having some sort of even within country, having some sort of tools that can be applied if you are, for example, at a big hospital where you have access to diagnostics, as opposed to somebody who's at a lower level of care, having some very simplified tools that healthcare providers can use, and then they can be supported to use them, that would contribute to increasing the uptake. I think those were my thoughts.
Mm-hmm. No, thank you. And I would like to come back to you about kind of further thoughts and linking this study on diagnostic algorithms to diagnose TB clinically and ability to offer treatment shortening for kids. And we can talk about it in a minute. Gareth, I can see your hand raised.
Yeah, thank you. And I was very struck by Berta's data that shows within the responses that you've had that we've had very few responses from colleagues in Latin America. And this is really mean, but I can see that Christina from Brazil is on the call and is one of my colleagues on the Network Engagement Committee. And Christina, would you be willing just to say why you think it's difficult to reach the colleagues in Latin America, and what can we do to help Berta and everybody to get more responses from particularly the countries that haven't responded at all? I imagine you were probably the person who responded on behalf of Brazil, but what would you say if you're out there, Christina? And apologies for putting you on the spot like this. Well, actually, anybody else from Latin America on the call? How can we help the Berta and colleagues to get more response?
I think we ask Messi to get shine when he gives his interview when they are in the final of the World Cup. Then everybody will respond.
Yeah, they could put a notice on the playing field, couldn't they?
Absolutely, not a big deal, really. Okay.
Okay, maybe that hasn't reached Christina. Never mind. Okay, thank you.
Thank you, but we're trying. So we're trying to reach out and get a little bit more responses from Latin America, and I think Berta, like South Asia as well. They were we were expecting a little bit more, especially like Far East Asia that we don't have responses as yet. And but it's interesting to see the snapshot. But in terms of like the biggest problem, I think, and the biggest thing, kind of gap in childhood TB are missing kids. And it's estimated that there are really millions, actually, I think, not diagnosed. And there is quite a lot of postmortem studies showing that we are missing TB in children. So there is a big push of using the clinical approach or clinical diagnosis. And Chishala, I know that you've been involved in this implementation study, because the WHO have got this beautiful algorithm, for the settings where chest X-ray is available, for the settings where chest X-ray is unavailable, and to enable clinicians to diagnose TB on the clinical grounds. So do you think, this clinical diagnosis and TB treatment shortened because if a child is well, like certain age that we are confident they don't have some sort of subclinical cavitary disease, which is probably difficult to imagine but may happen. That's why adults are worried. Then you can, if you score certain kind of a score like above 10, I think, or above 17, then you can enable clinicians to start treatment. And if the child is very well, they may really start a short regimen and then review in 4 months, provided the response was very good. Within 1 month, all symptoms disappeared, and adherence is reassuring. At 4 months, if everything is clear, they can stop treatment. Would this is your project? I think it's called Decide, going to evaluate alongside this clinical algorithm and TB treatment shortening or not? And do we need another implementation study to do that? Because I think I can see that the chest X-ray are the main barrier, that people either don't have access or don't have a confidence enough to say whether it's severe or non-severe. So removing this chest X-ray, maybe could give us a chance to start diagnose more kids and start treatment early and give shorter treatment.
Yeah, thanks, Anna. So just in a nutshell, what we're doing in the Decide TB is that we we're doing a validation of the WHO algorithms that they recommend. And for people who are not aware, they recommended two algorithms, algorithm A and B, where in one algorithm you can include chest X-ray findings plus the clinical features to get a score. And above a certain score, which is about 10, you then initiate treatment. And then they also then propose another score that can be used in a setting where they don't have HSX, for example, a primary healthcare facility, based on symptoms and clinical features. And so these are the two algorithms that we were implementing. And then in addition to that, we then added, I don't want to call it an algorithm, but we added a tool that when they've scored the child, then they then use it to guide them on whether a child should receive 6 months or 4 months using the criteria as specified by WHO. And we have been implementing this in Zambia and in Mozambique. So we have some preliminary findings and we'll be sharing this at the union, but basically there was some increase in the case detection, but obviously we need to look at that closely because we have another study that looks at whether how many of these TB diagnoses met the criteria for TB for us. But in principle, we noted an uptake in the number of TB cases that were diagnosed. We're still yet to analyze the component of the treatment shortening, and we'll be providing that hopefully by the end of this year or in the first quarter of next year.
That's amazing, Chishala. Looking really much forward to that. And we just recently been to Nigeria on the Penta training course. The TB colleagues were really keen to have another TB focused training course, and we were talked a lot about enabling clinicians to make TB diagnosis based on clinical grounds. There's lots of a bit of hesitations. TB is still seen as a kind of specialty diagnosis, and I think we need to do a huge amount of more education training and building confidence. I wonder if anybody else wants to share your thoughts or reflections. Would be good to hear from Uganda. I can see quite a few colleagues from Uganda and Zambia. And also, I think we have some colleagues from Canada. If I remember correctly, Canada was one country standing out that actually was very hesitant to implement and adopt kind of TB treatment shortening in their national guidelines. It would be good to hear the reasons why.
Maybe as people are still waiting for another hand up, I've got a question just to clarify. It's similar to Gareth's question to Chishala. So you said HIV infection and wasn't irrespective of HIV status was not a variable that led to different outcomes, if I put it that way. What about the degree of malnutrition? I see I've got a phrasing that says it did differ by weight band. What about, did it differ by the degree of malnutrition when present, Sam versus man? Was that investigated? Because I'm just trying to ask that question in the context of the same thing that some clinicians are hesitant to go for the 4-month regimen. Was that investigated? Was that there or not? Or does that make you have what might not be uncomplicated TB? Just trying to really get back to the barriers in comfort the clinical team has to adopt the regimens, the reduced treatment regimen.
Yeah, so I think in my presentation we had pre-specified an analysis, the particular groups that were specified and analyzed on whether there was any difference, and this included HIV status, the gender, the age, and the weight band, and the forms of TB, whether it was biologically confirmed, microbiologically confirmed or not. And if we looked at these parameters, there was no difference. The results were consistent on whether you were on 4 or 6 months. The children who were deemed to have been very sick with severe acute malnutrition were actually not included, but we had a few children, for example, if they were treated and they were enrolled at a time when they were stabilized, some of them may have been in the trial, but I don't think that we had a lot of those, and there was no pre-specified analysis for them. And I can add if there's anything I have missed.
No, thank you, Chishala. Am I on mute or not?
No, we can
So
hear
hear
you.
me. That's great. I remember we did this analysis. It was shocking to see that actually in both arms, children with HIV did worse than children without HIV, but there was no difference. If I remember correctly, there was no difference between a short and long treatment. The main thing was striking, I think, was anemia, isn't it, Chishala? That's hemoglobin was one of the
anemia and malnutrition.
And malnutrition, yes, go head in hand. But we were very clear that in SHINE we didn't include severely sick. So child who is severely sick was an exclusion criteria, and rightly so. You know, if a child is clinically sick, they probably need a longer treatment, and they may not respond very well, and they face, drug interactions, and could have some toxicities, and it's difficult to tease out. But it was reassuring that we did not see any difference. Though the group was quite small, there was no indicative shift that actually children with HIV do any worse. If anything, the point estimate, Chishala, I think, was towards the short treatment. Maybe they just did better in a little bit, but the confidence intervals were quite wide. I can see Kevin raise his hand. Hi, Kevin. Where are you from?
Hi, and I'm from Zambia. I just wanted maybe to make a comment and say how the implementation of the shorter treatment regimen was for our country, and maybe just also to thank, I think Dr. Chabala was keen making us be one of the few countries that did implement the shorter treatment into the program. I think after incorporating it into the guidelines, and you saw in the presentation he made, we did take into consideration, I think, age. The trial was 3 months to 16 years, but because of our reporting systems in Zambia, we aimed below 14, so we couldn't incorporate children that were above 15 to meet the criteria, so we went that way. Then I think one other thing we noted in implementation is that we had more children coming in from lower level facilities, which actually showed that the children who are quite not very sick, and if a diagnosis can be made early, then they will qualify more to be onto the shorter treatment regimen, which is the 4 months. And then we also implemented it, I think, in the phased approach. I think we picked our 2 highest burden provinces, which is Copper Belt and Lusaka. And then when we saw that what we had learned, and then we scaled up to countrywide implementation. And seen there's still a review. We haven't yet completely gotten back the results of what the final review, how well the implementation has been, and how many children were actually moved from the 4 months to 6 months at implementation. I think we have a review that is being done with support of CDC through CIDERS to review how the implementation is and was going on at the time. And I think that's the same what I wanted to share. And I think that, like you said, it's moving from. We thought the SHINE trial would easily be put into practice, because I think it was designed to be almost similar to what is done in practice, but when it came to implementation, it was a bit different. So I think the implementation science bit of it has shown us that there are a few things that could be done. That's my submission. Yeah, and we have other people on the call that I think can submit from Zambia that were very instrumental in us implementing this short treatment regimen. Thanks.
That's great. Thank you, Kevin. It's really great to hear. Yes, I think, big main is learning lesson for me, need to learn more about implementation science. And that is, we have tools now, but ability to implement the results and make things practiced in the world. That's a challenging bit that we need to master. Dai, last word for you.
Just a very brief word. I mean, I think what Kevin's just said and saying, well, Chishala had a major part in getting it implemented. Implementation needs a champion, I feel, and I mean, clearly knowing that. I was interested at the meeting in the UK last week where people were talking about TB treatment shortening, and obviously that's gone ahead. And one of the reasons it's gone ahead is that the formulations we've got in the UK, which are liquids and much more difficult to take than in low and middle income countries with the fixed dose combination, they really wanted to shorten because all the families were saying we can't take this for a whole 6 months. And actually having champions for implementation is a really important. I think, Chishala, you've obviously been a big champion for Zambia. Thanks.
Thank you, Dai. Thank you very much. So what are the next steps? How can we do better? What are your vision, for the maybe next trial, Dai and Chishala?
Well, maybe I'll let Chishala speak, but I mean, I think I heard two things. One is if you could not have to divide into mild and severe lung disease and you could shorten for all of them, that would be great. And maybe that question needs answering. And the second one, I suppose, is also, well, could you go even shorter? And for those of you who've been part of PEDICAP, for example, there are designs of trials where you look at really the shortest you can go while maintaining the same efficacy. But Chishala, do you want to say something? I think there is thoughts from quite a group about moving that way in terms of asking further questions in trials.
Yeah, Dai, as you rightly pointed out, I think from what we're learning so far, this challenge of disease stratification seems to be coming up a lot more. And so the proposal of having a shorter regimen that you can implement across the different disease strata would be quite helpful, and would probably be easier to implement and would not require lots of other, would not be dependent on lots of other things like chest X-ray and everything. That's certainly worth considering, and we've designed some proposal that we submitted to try and see if that could be answered. And then also the other thing, just coming back to what we've been talking about, is I think also having countries share their experiences. For example, the countries that already started implementing and they've learned, they've seen what works, they've figured out a way to go around those things. Having these countries share their experiences would also help other countries, because what I've noticed is that when people see that other people are doing it, they kind of find it easy to overcome whatever barriers that they are perceiving, are present in the implementation of a recommendation.
Mm-hmm. Thank you, Diane. Thank you, Chishala. Good thoughts, and all the best and good luck.
Can you just catch Christina's question?
Yeah, Christina's got a question.
It's such a nice question.
So, Christina, do you want to voice your question? Do you have a? Can you switch on?
Yeah, sorry. Yeah, hi. It's just asking for when we try to design a trial that we could use all the kids, not also the severe ones. Could we use the response after the first month of treatment to use shorter treatment? Because I know the kids who had a good response earlier, they tend to even abandon the treatment earlier. So it would help us in the practice a lot.
That's a wonderful question. Thank you, Christina. Dai, what do you think about treatment response guided duration?
Yeah, I think one of the slight problems with it is, of course, that the children who do well, and it is I think, Chishala, I'm correct in saying is that it's sort of part of what WHO guidelines have said, you know, that the child who isn't very sick, maybe you haven't got a chest X-ray, but you're able to follow them up. You see they respond really well. You don't think they had severe TB. You could therefore make a judgment about stopping at 4 months without any problem, you know, and you feel okay about it. But doing a trial that way, what you will do is the children who don't respond well after a month, then you won't even consider putting them in the trial, if you see what I mean. So it's quite a difficult question to answer, where you're depending on what happens after you've gone into the trial to manage. But I think it's worth putting one's head into it to actually say, could you ask some questions which relate to that very important clinical possibility?
Yeah, I don't know, or maybe 2 randomizations, the first one and then the second one after the response. I don't know, just
yeah. I mean, they did that with some of the pneumonia trials. You know, can you stop treatment in community-acquired pneumonia after 3 days versus 7, for example? And the trouble is that, of course, the ones that weren't very good at 3 days, people wouldn't randomize because they were going to continue treatment anyway. So that's the sort of issue which is a bit difficult with a design like that.
yeah, I
I
understand.
don't know if I've
Thank you,
explained myself very well, but it's certainly
yeah,
worth.
you did say, yeah. It will be a bias, yeah, understand.
But thanks for that.
Thank you very much. Oh, thank you very much.
That's great. Thank you, Diane. Thanks, Christina. Thanks everyone for taking part in this webinar. I think we will need to close. We're already like a few minutes overdue. Tisu, any last words?
I think my last words, I think you've heard this many times, but congratulations to the SHINE team. I think maybe you're thinking so much about implementation, but I think you did a great job on the first step in giving us the world, the science. I think right now what we're trying to tease in is how to put this into the real world. So I think let's continue thinking about other ways of doing that through either other trials and or implementation science. I think at least implementation science is needed, but we can still think of other trials because we still have questions that are related to the barriers. But all in all, congrats to the team. Let's continue thinking about it and all the bests. Back to you, Anne.
Thank you very much, Tisu. That's very kind words from you. And I wish, Dai is amazing chief investigator. She also always have visions. So Dai, thank you very much for giving us the SHINE trial. And thanks for everyone to taking part in it, and hopefully we'll have SHINE too.
Can I just add in Peter Donald, who some people might remember, a really quite famous pediatrician from South Africa. Really, this was his idea, and he'd been talking for a long time about. And Mark Cotton took up the flag, said, "Can you look at shortening? Because a lot of kids probably don't need so much treatment." And it is true that this has made the adult lot think about stratified disease as well. So they're all thinking about what you could do in short. So I think it has had some wider effects as well. But I wasn't the first one to have the idea.
That's great.
It came from the ground, as it should.
Fantastic. Thank you. Thanks, Dai. Thanks, everyone. And thank you. And have a good day. Have a good evening and the rest of the day where you are.